afternoon, everyone. My name is Natalie Slaughter, and I am the Director of Health Integration at the Association of State and Territorial Health Officials, also known as ASTHO. I would like to welcome you to today's webinar on telehealth program development and policy. ASTHO is committed to supporting state and territorial health officials and their leadership teams within the transforming health system. ASTHO, with support from the CDC, Office of State, Tribal, Local, and Territorial Support, and in partnership with the Center for Connected Health Policy, is providing this webinar to facilitate the sharing of best practices and lessons learned related to telehealth. This webinar is scheduled for 1 hour, and time has been set aside for discussion with participants and to answer your questions. In an effort to reduce background noise, we ask that you mute your individual phone or handset during the presentations and when you are not speaking. Also, please do not place the call on hold. If you have a question during the call, you are welcome to post it to the chat box on your screen at any time. These questions will be answered during Q&A at the end of today's presentation. We will also open the phone lines during the Q&A session for you to ask additional questions. At the conclusion of this call, you will be directed to an evaluation survey. Please take a few minutes to complete this survey, as we would appreciate any feedback you have. This is very helpful to inform the future work of ASTHO. Now I'd like to introduce today's speaker. Mei-Hua Kwong joined the Center for Health Policy, also known as CCHP, in March 2010, where she works on public policy issues as they impact telehealth on the state and federal level. She is also the project director for the National Telehealth Policy Resource Center. For CCHP, Ms. Kwong manages projects, provides policy technical assistance to state and federal lawmakers, industry members, providers, consumers, and others, oversees the CCHP policy staff, and works closely with CCHP's partners and consultants. She has authored several articles published in peer-reviewed journals and has presented at national conferences. Ms. Kwong holds a BA in International Affairs from George Washington University and a JD from George Washington University Law School. Now, without further ado, I'll turn it over to Ms. Kwong.
We're focusing on Oklahoma, but there's actually quite a bit of information that can be translated to other states. I'm just using Oklahoma as some of the more specific examples of some of the policy items out there. So before we get started, though, I always have to do a quick disclaimer. So please know if I happen to mention any product or any company, know that CCHP nor I have any type of financial arrangement or agreement with such company. CCHP is completely nonpartisan or nonprofit, and what we look to do is really to advance telehealth policies in health systems in order to promote better health outcomes and provide greater health equity and access to affordable quality care. So as Natalie mentioned, one of the things that we do at CCHP is we're also the National Telehealth Policy Resource Center. What that means is it's a grant from HRSA, and we work with 13 other resource centers. 12 of them are regional resource centers, so they cover specific states. And there's also another national center. It's on technology. So I like to call the resource centers your one-stop shop for all things telehealth. So if you have a question regarding telehealth, practically any type of question, you can reach out to a resource center, and they will find the answer for you. They may not know the answer themselves, but we all work collaboratively together. So really what you're getting when you reach out to one is 14 organizations helping to resolve your question or your issue that you may have. One of the things we do as the Policy Center, though, is that we track the current laws, Medicaid policies, and regulations related to telehealth on both a federal and a state level. That's a snapshot of our website. It's our interactive map. So we've organized the information by state. So you can go to our website, click on a state, and it'll bring up all the information that we were able to find. This is information that we keep regularly updated, and we actually just released our most current update yesterday. So the information you'll find on our website is good up until March 31st of 2017. And as you can imagine, when you're looking at basically 51 jurisdiction, if you include DC, that's quite a task to keep that updated, but we try to do that as regularly as possible. So just kind of an overview, just to make sure we're all on the same page. Telehealth is really the use of technology to provide services, health services from a distance, where the patient and provider aren't in the same location. So there's 4 modalities in providing telehealth. One, the one that most people are familiar with is synchronous or live video. That's like a real-time interaction between the patient and provider, or it could also be between provider and provider. Next one is asynchronous or store and forward, and that doesn't take place in real time. It's the capturing of information and sending it where the provider will look at it at a later time. So for example, what you see there in the picture is an example of that, of someone taking a picture of a skin condition and emailing that presumably later to like a dermatologist, who can then evaluate it and send back a diagnosis or a consultation or further notes. Remote patient monitoring actually uses elements of the other 2. It's the continuous monitoring of a patient, and it can be in real time or not in real time. A real-time example might be an ICU unit where you may not have the intensivist on-site with the patient, but monitoring from a different location, and then being able to relay back to healthcare providers who are there physically with the patient. A non-real-time example of remote patient monitoring is perhaps you have the patient at home and they have hypertension, and they're taking their blood pressure readings on a daily basis and sending that information to their physician or to a nurse. And that healthcare provider is not looking at it as the information is coming in, but probably looking at it at a certain time, maybe looking at all the data that's coming in for the week and making any types of adjustments necessary. Health is sort of the newest area for a telehealth modality, and it incorporates all of like the 3 previous modalities in some way. But basically, it's the use of some sort of handheld mobile device, your cell phone, your iPad, a laptop, and it's primarily being used through apps. But it's also the least developed policy area for telehealth policy. There's really not a lot of firm laws or regulations around health right now, and there's been a lot of concern about that because you have a lot of apps that are being out there, and how are they being regulated? There is a little bit of guidance and policy around it from the FDA on like the software or the equipment itself, but as far as like other policies around it, it's very few. So the beauty of telehealth is that it just goes beyond providing healthcare services. It could, it has impact on training, not only for providers, but also for patients and their families. It's information sharing, it's data collection, it's care coordination. So there's a multitude of uses for telehealth. And if you're starting a telehealth program, you got to kind of decide on like, well, okay, how am I going to use it for what I want to do in my organization and to achieve like the goals that I want out of it. So we'll start with program development, and I'll warn you, this is very high level. These are just sort of like, they're the starting things that you should consider. If you want to go a little bit deeper, I highly recommend that you contact your regional telehealth resource center. That's what they're there for. They can help you dive a little bit deeper in helping you develop your program, answering your questions, and so forth. But these are kind of like starting points that you might want to utilize when you're thinking about starting telehealth. Just broadly, you want to assess and define, you want to develop and plan, and then implement and monitor. Those are kind of the 3 major buckets of where you want to start. So assessing and defining. First, you need to figure out, what are the potential opportunities out there, and that might include sort of an assessment of what your community needs right there, what type of services, and how can they be delivered via telehealth. As a telehealth proponent, even I say, like, not every service is appropriate to be used using telehealth for it to be delivered. So you need to decide, like, what services can be used or can be delivered with the use of the technology, and if that works for, like, what you have in your organization. Then you need to make sure that there's actually going to be an impact and like what sort of demand there might be in the community. So you have to kind of figure out if your patients might actually be open to telehealth. it's not going to work if the patients and the providers who are delivering the telehealth services aren't really enthusiastic about the technology itself. So you have to see if there's the demand there. You also have to determine whether you have adequate resources to devote to starting a telehealth program. I know this is an issue that I run into with a lot of policymakers, at least, when they say like, oh, well, we passed a telehealth law, everybody's going to use telehealth now. And it's not quite that easy. There's actually quite a bit of investment on the provider side in starting a telehealth program. And I'm not just talking about purchasing equipment, but it's really a disruption of services, how you deliver your services within your organization. So you have to determine, like, the workflow, staffing. Does your current staff, are they the staff that you really need to do the telehealth program, or do you have to hire more staff or like have more training for your current staff? And then again, like their acceptance of this. Will they want to utilize telehealth in delivering services? One of the areas where there is that impacts the utilization of telehealth is provider buy-in. If the providers don't want to use the technology, it's going to be very difficult to have a successful telehealth program. And then you need to decide how you want to go about doing this. As far as like what type of specialty or services that you want to offer. And that's not just only deciding what modality you want to use, but the type of services. Do you want to just do it for mental health services? Do you want to do it for dermatology? Do you want to do it for other things? And it's not only whether the technology is appropriate for it, but whether you actually have a specialist who could provide those services as well that you can contract with. We actually at CCHP have run demonstration programs, and we also help a lot of small rural health clinics or community health centers, FQHCs. And one of the pitfalls they kind of fall into sometimes is getting embroiled in a bad contract with a specialist. And I'm not saying like, they're a terrible specialist, but what I'm saying is sometimes they get into a contract where they may not be able to sustain that contract because they don't have the volume for either that specialty, or the contract's arranged in a way that they're not able to like have the volume in order to make that contract worthwhile for them. So you have to really assess whether there is that demand for that specialty that's going to be utilized for telehealth, and also whether how you structure that contract with specialists, if you need to do that contract. Sometimes you might be an organization where you're lucky and you actually have like the specialist on staff, but that's less of an issue. And then like with your business plan, beyond the demand, you got to like figure out, how is this going to be paid? So you got to look at the policies that are out there, not just only the statutory policies, but policies about the health plans who are operating within your region that your patients are primarily using. Are they covering telehealth? And then how much are they covering telehealth for? A lot of plans, a lot of laws leave a lot of outs for folks on the reimbursement side. So, and the outs might be they limit it to certain specialties, they limit it to certain services, or they can even have a different amount that they reimburse for. So you need to see, like, is this going to be sustainable with what they pay for what's being paid in for the services. For a lot of telehealth programs, a lot of them started off with grants, some type of grant to like get them started up with, but once the grants run out, a lot of those programs just kind of wither and die away on the vine. So it's really, really important to, figure out, is this program going to be sustainable after, the initial investment, whether you're using a grant or you're putting in your own money. So develop a plan, and this is kind of self-explanatory. It's all the important details that go into it. It's like, what technology are you going to use, and then what are you going to buy? That's always very important. I can't stress enough. If you're like a community health center, small clinic, I get people all the time asking me like, oh, should we hire a consultant? And then I always say, stop right there. Check with your regional telehealth resource center first, because what they do is free technical assistance. So before you go off and hire a consultant, check with the resource center, talk with them first, and then if they don't give you what you need, consider then hiring a consultant. But they can probably help you with a lot of the things that a consultant will initially do for you, and you get that for the most part free. I mean, if you're taking up a lot of time, they may talk to you about, like, you know, we might have to do a contract, but a lot of your initial questions, especially around the technology, they can help you with. Especially the National Technology Resource Center, great for that. So you want to create a detailed plan, and you want to look at various things like the staffing, like I mentioned earlier. But another thing, two things that actually a lot of people kind of overlook sometimes is your broadband capability. You're using telehealth. You're using the technology there. You're going to need that broadband. That's going to be very important. Your current broadband width may not be enough to make your telehealth system work or your telehealth program work, because it actually does take up a lot of space. And the worst thing that can happen during a telehealth interaction is if the connection fails or it goes really slow and is choppy. You do not want that to happen. It could be devastating if you're like at a very sort of delicate point, like especially with like a telemental health consultation or something. So you want to make sure that that broadband capability is there. And also space. So again, you know, unlike some policymakers, when I talk to them, it's not just like, oh, you suddenly have a laptop and you can just like do that. No, you really want to consider your space as well. And this also feeds into your technology. So if you have like a small space, most likely buying like a huge cart that it will be like stuck in one room may not be like the best option for you. You might want something a little bit more mobile that you can move to like various rooms or something. Or, you know, that might be like the best thing for you, is like having something that's huge and stationary in a room. So look at your space as well in when you do your developing. And also have some type of performance monitoring plan. This will help you figure out, you know, any types of glitches and how to address them. But also it will help you with your sustainability as well, because it'll give you an idea of what your volume is and maybe ways to like increase your volume or create efficiencies in order to be a little bit more sustainable in your program. Implement and monitor. Okay, when you're ready to go, when you're ready to launch, do a couple of dry runs. So you want to check those out, do a couple of test runs before you actually get into it, because again, like that's the last thing you kind of want happen if something goes wrong during an actual consult, because not only does that, you know, make you less comfortable and make you believe less in the technology on your provider side, but then your patients aren't going to want to use it. And then you never know what they're going to say to, like, you know, their friends or something. They said, oh, I tried that telehealth thing, it was terrible. And then you'll have, like, resistance from the community then in using it. So, you know, try some dry runs first to, like, work out the kinks. It's going to require a lot of patience because things will, it's technology, inevitably, you know, especially when you're just starting out and testing things, there's probably something that's going to go wrong. And there's always room for improvement and efficiency when you do this. I'm going to be very frank. Probably when you start a program, when you launch it, you'll probably operate at a loss at the beginning. You're probably going to have to be ready to and prepared to put in some money in it for at least a year before you break even or even like see a profit. So that's just the nature of what this is right now. So just be aware of that. So here are a couple of resources for you. So all that information that I just told you about, that was all high level, and it actually came out of the developer's kit that was put together by the California Telehealth Resource Center. It's available on their website, but you can also access it through like any of the other TRCs. Because I did sort of focus in on Oklahoma for this webinar, I only put Heartland, who covers Oklahoma, their URL up there. But if you look at where that photo is, at telehealthresourcecenter.org, that is like the central site for all the TRCs. So you can just go there and find the TRC that represents your region and contact them. And these are a few of the things that they have available for them. And as I said, most of their services are free. So, I mean, even if you just have a general question, they're happy to help you as well. And if they don't know the answers, they reach out to the other 13, and I would say 99.9% of the time, somebody's able to answer the question for you pretty immediately. If they're not, we usually go and try to hunt down the answer for you. But what are the policies you need to know? Because for one thing, when you start a telehealth program, A, not only do you want it to be sustainable so you can continue it, but B, you want to make sure you're not violating any laws or any regulations. So you don't want to get in trouble when you're using telehealth. So there are a couple of general legal and regulatory issues that you should be aware of when you're starting out. Licensing, credentialing, privileging, prescribing, HIPAA, informed consent, malpractice, AntiKickback start clause, reimbursement always a biggie, and then any pending legislation or regulations. So again, this is kind of high level, but I think you're able to access these slides. So I'm just going to go through this quickly, but I'm always happy to answer questions later. Licensing. So the beauty of telehealth is that you can cross state lines if you're a provider. But the problem is that each state requires you to be licensed within their state in order to practice and provide services to citizens of their state. So you do need like a license if you're going into a different state. You do need a medical license in that state. I'm sure a lot of you have heard things about like the licensure compact. So yes, there is an interstate licensure compact for physicians. It is an expedited process to get a license in another state that's a member of the compact. It is not a one license, multiple states you can practice in. So be aware of that. They are, I believe, they definitely have like the entity form to like administer the compact. They've run into a couple of issues in a few states, and sort of like follow-up legislation had to be passed. But they're just about there. I think they ready to launch. I don't think they've launched yet, but they're getting very close. If you're a nurse, there is a nurse licensure compact, which is a one license practice in multiple states. So there is that as well, and there's also a psych contract, a psychiatry compact that only 2 states. I think Arizona was the most recent one. Only 2 states have been have passed legislation on. So you do kind of see like these compacts out there, but aside from the nurses one, I don't think any of them are like you get one license and you can practice in multiple areas. So that has remained kind of an issue for telehealth spreading a little bit further than it could be. Credentialing and privileging. So probably most of you are aware of this. When you are a physician and you're practicing in a hospital or clinic, you need to be credentialed and privileged. There was an issue when the ACA was passed that eliminated a process that had been used for telehealth in that you could use wherever the physician was based, use their sort of credentialing background information at my home place because he would be providing telehealth services to me. Use all that information so I didn't have to go through that expensive process. And that really helped out a lot of the small, rural community health clinics who, needed those specialty services but probably couldn't go through and afford a full credentialing process for them. So there was like kind of that shortcut way for them that they can just rely on what was done at like the physician's home base or home organization, rely on what they did to make their decisions for privileging. ACA said like, you know what, if you're getting Medicare money, that's not going to fly. That process is not going to fly. Surprisingly, the feds moved actually pretty quickly. So CMS introduced like draft regulations on addressing it. That was basically the same process. They had a bunch of other, little hoops that you had to go through, things that you need, conditions you need to meet. But the concept of, yes, you can use the specialist's home organization, what they did for the background checks and everything to make your decision so you can credential and privilege in your organization. So those are the regulations related to it. So there were the federal regulations, and then the Joint Commission did comparable regulations like 6 months later, improved them. These are some of the general things that you need to do for underneath the federal regulations. Likely the big thing about it is it required like a bylaw change to say that you would use this process. That is like the one thing that I have heard has been kind of a stumbling block for folks in utilizing these regulations. In that's like an internal thing where it's either very difficult for them to do a bylaw change or there was unwillingness to do it. Also note that this credentialing and privileging process, it's optional. So if a hospital or critical access hospital decided they wanted to go through the full credentialing process itself, they can. This is strictly optional to do it this way. So pretty self-explanatory. There need to be like a written agreement. They needed to say that they would do this. There needed to be an internal review of the services the telehealth providers was providing, and then if they got any complaints of like what that provider did, they need to like send it back to like their home base to tell them we got some complaints about your guy on this. And then what are the distance site obligations? They needed to be privileged where they were. They needed to provide like a current list of what they can do, what they were privileged to do at their home site to like the one who's now currently receiving the services via telehealth, and they needed to be licensed. Again, here's that licensing issue. They need to be licensed and recognize the state of like where they were giving services to, the originating site. Again, the Joint Commission qualifications or requirements are pretty similar, so I'm just going to skip over this really quickly. Prescribing. Big issue has become a much bigger issue over the last 2 years, I would say, as far as like state legislation. So prescribing, it's a couple levels. You have like your federal level around controlled substances and how they treat telemedicine, and they call it telemedicine, how they treat telemedicine when prescribing. And then you have state laws and what they have for prescribing. So controlled substances, you're underneath what the feds say. It was there was some telemedicine exceptions made for prescribing of controlled substances underneath the Ryan-Haight Act. A lot of that has to do, basically, they want like the patient with a physician. So they were trying to avoid the whole, patient like just goes on the internet, connects with a doctor, and gets a controlled substance prescription. So kind of the exceptions that they make for telemedicine typically requires like a patient to be physically with like another, not necessarily a physician, but maybe like a healthcare provider, like in some type of licensed clinic. But you have state prescribing laws, and this is where a lot of activity has happened over the last 2 years. So state prescribing laws, because the question has come up: can you can you establish an adequate patient-provider relationship if the relationship has only been done via telemedicine? And part of that issue has been like, can you do like an adequate initial exam of the patient and get like the history that you need where you can safely do a prescription? So the states are kind of split on this. There are some that say, yeah, telemedicine works if, the physician feels like they got the information that they need in order to do that. Others say like, well, no, they need that in-person exam. Or they kind of even split it finer and say like it works in some situations, but it doesn't work in this situation. And then others are really kind of vague. Some of them, like Oklahoma, says, well, a sufficient exam needs to take place. But a lot of times they don't quite define what that word sufficient means. California is the same way. California uses the word appropriate, but there's no definition of the word appropriate. And I've spoken with the California Medical Board saying like, well, how's that defined? They said, well, the law just says appropriate. So it's that gray area. It's like, what is a provider supposed to do? So whenever I'm asked, at least for California folks, saying like, well, what are we supposed to do? And I say, first off, I'm not giving you legal advice, but the law says appropriate. This is what I've heard people doing. Some feel like if they get the information that they can, and they're not jeopardizing the patient's welfare in any way, that they think that they've done an appropriate exam via telemedicine. Others who, a lot of reasons because they're citing, just being extra cautious here, they will require like an in-person exam. Or what they would do is, especially if you're a specialist seeing a patient and they've been referred by a primary care provider, is that the prescribing is done through the primary care provider. So the specialist would say to the primary care provider, hey, I think they need this type of antibiotic to clear up X, so, if you make the prescription. So that way they kind of avoid it because the primary care provider is making the prescription, not the specialist. So that's for prescribing. HIPAA and privacy, again, a lot of questions usually around this. Now, and it's tricky in that there's nothing specific about telemedicine or telehealth within HIPAA. So you're still held to the HIPAA standards, but you just have to think of things a little bit differently. And I always caution, I know a lot of people when they go to to a vendor and they say like, oh yeah, my equipment, if you use my equipment, if you use my software, you'll be HIPAA compliant. Well, that's not the only thing that makes you HIPAA compliant. There's probably like features or aspects to the equipment that help you meet HIPAA compliancy, but HIPAA is also actions of like the provider that they take to ensure that they meet the standards that HIPAA set. So it's still the same thing. You still need to meet those standards. You just got to think about things a little bit differently. And by that I mean when you're using telehealth, I call it a disruption of services. It also kind of disrupts the way you do privacy because you need to think about things a little bit differently. For example, you might have in your office, if you're doing all your services in person, a staff person who was like your tech person who maybe just usually fixed the printer or, fix the fax machine or something like that, and would probably not be, involved in any type of exposure to personal health information, which HIPAA protects. So, but then maybe when you switch to delivering telehealth, suddenly that IT person takes on a much more important role. Maybe they're troubleshooting the equipment if something happens like during an encounter with a patient. So yeah, then probably you want to give them HIPAA training at that point. So that's what I mean about thinking things a little bit differently. Also be aware of any state laws around privacy and security as well. So it's not just about HIPAA, it's also what your state might require. There are some states that are pretty stringent. I'm based in California, and California has some pretty stringent privacy laws, especially around health, but also around the internet and telecommunications. So that can impact you as well, depending on how you set up your telehealth program. For example, in California, they have laws about, if you're offering services in California via the internet, you need to have certain information on your website, such as contact number, actual phone number where you'll reach a live person, and so forth. So there are those kind of other types of laws that aren't specific to health, but are specific to technology or the internet that you need to be aware of as well. So let's see. Informed consent and malpractice. The reason I put this up here is because about half the states have some type of special informed consent for telehealth. They said if you use telehealth, you need to get informed consent from the patient. So I just wanted to highlight that. Malpractice. So there's two ways of looking at malpractice. The first is we get questions about malpractice of hey, how many lawsuits have there been around telehealth? And to be quite honest, there haven't been a lot. The majority of what's been out there have been settled. So I don't know much details about them because usually once you do a settlement, nobody talks about the details. And there aren't really a lot of cases out there, but I think that has more to do with the fact that telehealth isn't as widely used as it could be. I think it's just a numbers game. The more telehealth is used, the more likelihood there's going to be more malpractice cases. The other thing to consider about malpractice is malpractice coverage. So if you're starting a telehealth program, check with your carrier. Ask them if you start using telehealth, will your insurance cover those services? Not all carriers will cover telehealth. Some of them do. Some of them say, yeah, it's covered underneath your current plan. Others will say, you know what, you need to buy additional coverage, and some will say we don't do that. Also, if you are crossing state lines, make sure your coverage works in that other state because not all carriers operate in all states. So you might actually have to buy another plan if you're doing a lot of services into, if you're in Oklahoma and you're doing a lot of services into Nebraska or something. You need to make sure that you're covered in Nebraska as well. AntiKickback, Stark laws. So basically where this can kind of be an issue, but it's really not issues because there's so many exceptions. Is that when you're getting money from Medicare, they kind of want to make sure that you haven't set up a scheme with somebody else where you might have a contract where you say okay, so yes, I'll make sure I refer to you all these things. To avoid all that, I wouldn't worry too much about it. Just make sure that you fall into one of these exceptions. And I have a couple examples here. If depending on what your situation is and what you're getting from somebody else, it could be a vendor too with equipment. Make sure you fall into one of the exceptions that they have in the laws. I just put this in here just to make people aware of it if they're not already. That this is out there. It could be a bit of a pitfall that you run into if you're not aware of it. If you're getting Medicare money. Speaking of money, so the big the big policy section, and this is where actually a lot of the telehealth policy out there is focused on, is reimbursement. So Medicare on the federal side, that is where the majority of your telehealth policy is, and that's kind of the history of it. Really not a lot of telehealth policy has changed much since really 2000. It was first introduced in 1997. 2000 was like a major change because what they introduced was very limited. They did a major change in policy in 2000, and not much really has changed in 2000. It's been 17 years. And you can imagine the growth of technology in that 17-year period, yet the policy of Medicare hasn't moved too much in that time. So actually Medicare has some of the most restrictive telehealth reimbursement policies in existence in the U.S. States are actually a little bit more forward-thinking than Medicare has been. And that's for a variety of reasons as well. Some of it political, and some of it is just still, not wanting to move forward. So Medicare, they only do live video reimbursement unless you're in Hawaii or Alaska, where you can do store and forward as well. There's a specific list of providers who are eligible for reimbursement, and that really does not include a lot of the allied professionals like occupational therapists or physical therapists. A killer is that you're limited to very specific geographical regions. The patient needs to be either in a rural health professional shortage area or a non-metropolitan fiscal area or within a telehealth demonstration project in order to get reimbursement from Medicare. That eliminates so much of the country. I'll use California as a reference again. Practically the entire state of California is eliminated from potential reimbursement from Medicare because the way they have the definitions, a lot of our state does not apply to it. They also limit the types of eligible facilities as well, basically to some type of licensed healthcare facility, so the home is out. And they limit the list of reimbursable services that you can get reimbursement for. So here's the list of eligible providers, eligible facilities. I'm not going to spend a whole lot of time on that. And definitely, don't strain your eyes squinting at this. Like I said, I think you can access or get a copy of the slides. But these are all the codes that CMS reimburses for if the service is delivered via telehealth. There's about 80 of them. Just to tell you how little telehealth reimbursement happens in Medicare, in fiscal year 2015, they paid out about $18 million for telehealth services out of a potential $600 billion. So yes, that's billion with a B. So you can just imagine 18 million out of 600 billion, very little. Other federal policy to be aware of. So what CMS had done, even though the law about some of the restrictions on telehealth has not changed or not moved, what CMS has done is done a couple of pilot projects where they're waiving some of the requirements, and some of that's happened with the next generation ACOs and the joint care replacement model. They don't remove or waive all the restrictions, which makes things a little complicated, I think, but they remove some of them, such as the geographical one. Other federal agencies to be very aware of, there's FDA, I talked about them a little bit earlier about the mobile guidance, but also look to the Federal Trade Commission. So for those who aren't familiar with it, the Federal Trade Commission, basically their mission is to protect the consumer by making sure there's no unfair trade practices across state lines or so forth. So they've actually started to get a little bit more involved in telehealth policy, even on the state level, which was unusual. They started doing that last year. The reason I point them out is, again, they can have an influence on how policy goes. Any type of court case can have an influence on how policy goes. So just be aware of what they're doing. And part of what they're doing is also looking at how regulatory boards look at telehealth. So they have sent in comments to proposed regulations by regulatory boards on the state level. And they've also been looking closely at how they do their regulations. So they're an important agency, I think, to pay attention to. In general, overall, state telehealth policies, there's about 44 states and D.C. that have a definition for telemedicine, and 33 states and D.C. have a definition for telehealth. Again, some states have definitions for both because they approach them differently. For example, they may regard telehealth as telehealth is remote patient monitoring. That's how they define that word. Two states don't have any definition. That's Alabama and New Jersey. Alabama had one, but for some reason they had deleted it. frequently reimbursed type of modality, live video. Store and forward remote patient monitoring, they're gaining a little bit of traction. For a while, their store and forward kind of plateaued out, but recently a couple more states are reimbursing for it. But for store and forward remote patient monitoring, there's usually a lot of caveats and limitations to what they reimburse for. So they might just only reimburse for certain conditions like diabetes, dermatology. They may have conditions on like the type of patient and their location. So even though they reimburse for some store and forward remote patient monitoring, usually a lot of caveats on what they'll reimburse for. Private payer laws. So on the state levels, you have your Medicaid programs and what they do around telehealth, but then you sometimes have a state who'll pass a law that says private payers, you must do X in relation to telehealth. So there's 34 states in D.C. that have like a private payer law. Be aware. So a lot of times people will say like, oh, a private payer law passed in X state, and now we have parity. Parity, you got to look at it from two ways. So parity can be coverage of service in that insurance carrier, you must pay for services whether they were delivered via telehealth or in person. However, what they don't say is you need to pay the same amount, and that's parity in payment amount. So be careful about that. And actually, most states do not say specifically that you need to pay the same amount. And that has not been an issue really for a while until about last year, a year and a half ago. New York passed a private payer law. They said you have to cover services, did not include language that you had to pay the same amount. And then a carrier in New York said, like, hey, all our telehealth providers, we're only going to pay you 50% of what we would pay if in person, because they did not have that language. They were well within their rights to do it because that language requiring them to pay the same amount was not in state law. So in New York, what happened, people became aware of it. A legislator tried to introduce a bill to address it, but ran out of time because it was towards the end of the session. So they're now trying to reintroduce that bill in this current session. So be aware of that as well, and also be aware of like how things are structured, how the law is structured and written, because there are sometimes loopholes within there, such as they say like, oh, you must cover these services if they're delivered via telehealth the same way you would in person, subject to the terms and conditions of the contract. Well, what does that mean? That can give an out to a health plan and saying like, well, my terms and conditions are I will only cover like these services and for these specialties. It sounds like they're within the law. So be careful when you examine like the private payer laws. It may not be as expansive as you think. So just really quickly, current Oklahoma telehealth policies or telemedicine, they use the term telemedicine. Oklahoma's Medicaid programs, they reimburse for live video, but they pretty much reimburse for practically everything from what I understand. So they actually have fewer restrictions than what other states do. They have a private payer law that's, again, pretty broad. It does exclude phone and fax, which is not unusual. If you look at policies throughout the country, the majority of states have something about excluding phone, fax, and email sometimes too, so that's not unusual. The healthcare provider determines the appropriateness of using telemedicine. There is no parity of payment in Oklahoma. Again, that's not rare. There's only, I think, about 2 or 3 states that have something very explicit. I think we'll probably see more of that happening in the future, putting in like that explicit language. And then for prescribing, there is a little bit of leeway in Oklahoma. I mentioned that earlier in saying that it's sufficient. So that is Oklahoma telemedicine policy. And here are a couple of resources for you. Our website, the Telehealth Resources website, and HRSA programs. Telehealth Alliance of Oklahoma, great folks working for telehealth in the state of Oklahoma. You can contact them, and then the Heartland Telehealth Resource Center, their website. And for states that may be on the call that I didn't really go over too much, I put a few bullet points for Kentucky, Massachusetts, and Pennsylvania as well here. And that is it. And I've talked for a long time, so I'm open to answering your questions.
Thank you very much, May, for your informative and engaging presentation. This was really helpful. We will now open the line for Q&A to participants. So if you would like to ask a question, either please type it in the chat box located on your screen. And I'm sorry, I did say we would open the line for Q&A. We are opening the Q&A portion of the presentation at this time, so please use the chat box at the bottom of your screen to submit any questions. At this time, we do have one question from Oklahoma, and the question is there any indication that CMS will allow local health departments to be accepted as originating sites for Medicare?
Probably not. I mean, like I said, so the sites, the actual physical sites, is a list that is in federal law, and they have not changed that since 2008 when they added like skilled nursing facilities and I think some dialysis centers. So it's a very specific list, and it's been difficult to like actually change statute on the federal level related to telehealth. So and quite honestly, I have not even heard of local health departments even being within the mix of potential locations. I think that's an oversight. And it's kind of an oversight with telehealth in general in that, you know, the telehealth in general, I think the telehealth community has, you know, grievously like overlooked local health departments and public health in, you know, like their outreach on telehealth and, you know, helping those folks. But yeah, that hasn't even come up, I've heard, in any of the discussions so far. But also, you know, just changing the federal policy, the laws in general, it's very, very difficult. Federal bills are introduced all the time trying to make a statutory change on the federal level, and they just kind of die in committee. But you know what? This with the new administration, don't ask me to predict anything because I can't. I don't know what's going to happen. So there might be a possibility. It's kind of like been a little bit unpredictable in D.C., but in previous years, it's just not really happened.
Great. Thank you very much, May. Another question that has come through, what states are considered models or like models for success in telehealth, specifically in programs of psychotherapy, diabetes management, et cetera?
So, you know, whenever I get asked this question, I said I've got to break it down in a couple of ways. So there's a model where you look at the legislation and maybe Medicaid policies and you think like, hey, that sounds pretty good. But then there's always like execution of it. So if you're looking just as the policy, the written policy and the statute itself, Minnesota actually has some pretty good language. However, that's recently passed, so they haven't quite gotten it implemented yet. And then, you know, after you implement it, you want to give it like at least maybe a year or two just to see how it goes and like get information. And, you know, it's too brand new for me to say like, yes, they're doing well. And also they're still in the process, I think, of writing some of the Medicaid policies to like implement all that. Hawaii is another state. They just passed a law, last year. Again, they updated their law. They had laws in place, but they updated their law last year, but there hasn't been like kind of time for it to go into effect. It just went into effect at the beginning of this year, so it's kind of hard to see what the impact is. But as I mentioned in my presentation, the law may look good, but how they implement it may not be as broad and as beneficial as you may have hoped the law would have been. And we are in the midst of finishing this darn report. It's still going through a review process where we examine the telehealth private payer laws and then like try to assess the impact of it. And it's very hard to assess the impact of some of these things because either somebody's not keeping data very well or the utilization has been so low. But we try to interview private payers and Medicaid in this project and ask them, you know, how has the telehealth been? What's been the uptake? And it's been kind of mixed. And a lot of times it's because, you know, there have been limitations thrown on the use of telehealth. And this goes back to, like, you think the law is, like, broad and everything suddenly is paid for regardless of whether you did it via in-person or telehealth. But no, there's other obstacles in the way. So if you're looking for, you know, models, it's really more not maybe states, but maybe more programs that are good sort of models in like how they've done telehealth. So there is the Avera program who does tele-ICU. They're in multiple states, and they've managed to make it work with good results. They've actually, I think, they've been evaluated by the federal government too. I think there was a HRSA evaluation of like their program for tele-ICU. So there are certain things like that. There are other programs that have had good results. I think a lot of you are probably aware of the ECHO program, which if you're not, it's basically like a grand rounds where a primary care provider might come to basically like kind of a panel over telehealth, over the technology, and they de-identify like the patient case that they're presenting, and then these consultants, these experts, like specialists, they give them like the sort of advice or their opinion on how the patient should be treated, and then the primary care provider goes and implements that treatment program. That's had very good success. Various programs, there's like various iterations of it. The starting one was with hepatitis, and out of Arizona, or was in New Mexico. I'm sorry, I sometimes get the two states mixed up in my head. They had very good results with like hepatitis and like serving a lot of rural communities who were impacted by hepatitis C. I've heard of ECHO being used in other ways to treat telemental health, to treat other conditions. I think diabetes is one as well. So you have certain programs. I'm not sure you would necessarily say states are models, but maybe programs are models. You have states that have, at least on this, initially when you look at it, good language that looks like it would be very beneficial, but then we need to see how that language is implemented within the state in their policies. And the ones that I would say look very promising and good, it's just been a little bit too soon because they've been recently passed for it to say whether, it's had like great impact after being implemented.
Okay, thank you, May. So while we wait on additional questions through the chat box, I was wondering if you could share a little bit more information about developing the business plan, and just if there are resources that might help, a state calculate how much funding, just other resources that may be available for developing the business plan.
You know what? I would check out the developers kit that I mentioned. It was created by the California Telehealth Resource Center. So if you go to, I just moved the slide here. If you go to www.telehealthresourcecenter.org and you go to the California website, they have a developers kit there. Now, you will see if you download the developers kit, I really just did not even 20,000 feet. We're talking 50,000 feet overview because their developers kit is about 300 pages. And it takes you step by step through things. So I would start with that and see if that information is there. But also, again, go to your resource center and ask them, because that's part of what they help you to do is develop a business plan. So, and they are out there. Like I said, the majority of their services are free. So if you're interested in doing that, contact them. And they can help you walk through there. But I would probably start with the developer's kit because maybe your questions are already answered there. It's a huge document. So that it's most likely buried in there at some point. But then if you want a little bit more specialized type of technical assistance on that specific area, I would contact your resource center as well.
Great. Thank you, May. So at this time, I think we no longer have questions at this time through the chat box. And so we've heard, I think, from our general audience members on telehealth programs and policies. But let's think about state policies on reimbursement. I know that you had touched on that, May, but I'm wondering if there are any attendees from Oklahoma that maybe have any questions or areas for clarification regarding Oklahoma's policies and reimbursement policies. And then if we have the time, we can also extend the same opportunity for the other states that are on the call as well, Pennsylvania, Massachusetts, and Kentucky. But I'm just wondering if there's anyone from Oklahoma that may have questions about some of the policies for reimbursement. Are there any state-specific questions from anyone on the line from Pennsylvania?
I will say if you're in Oklahoma, I have heard from Oklahoma Medicaid that, they are very open in utilizing telehealth. So if you are interested in providing telehealth service in Oklahoma, really look at the Medicaid program because they are limited to live video for the most part. So that there is that, but they seem to have much fewer restrictions than what a lot of states have, in that they're not saying, oh, it's only for like this list of services, or oh, it's only for these types of healthcare providers. So definitely look into that.
Great. And is there a website or a reference or anything that you would recommend?
Well, you can always go to our website, Center for Connected Health Policy, and you can always go to like our 50-state map. And then it's like a big orange button at the top of every page. So just like click on that, and then for whatever state that you're interested in, you can just click on that state on the map, and it'll bring up the information. And as I said, we just updated it, so it's good up until March 31st. But stuff can change because they're always passing legislation, and then like the Medicaid programs, they update when they update, so that kind of like shifts throughout the year.
Mm-hmm. Great. So with just a couple of more minutes left before we reach the top of the hour, I'd like to give any participants from Massachusetts or Kentucky who may be on the line a chance to ask any state-specific questions to May.
May, it's Lisa Randall from Massachusetts. In terms of some of the privacy and confidentiality requirements, public health has particular carve-outs, if you will. Have you had experience with that relative to telehealth, or is that somewhat of a novel area?
It's still a bit of a novel area, and I think we may have I may have mentioned it to you at some point, Lisa, in that we did a project here in California around TB and using telehealth. And so for treatment of TB, the recommended sort of treatment is direct observational therapy, DOT, where a healthcare worker sees like a patient ingest like their medication, and they have to like physically see them swallow it. So the question is, why can't you use technology? So because that will save like on driving out and like meeting them and like time and everything. So what they did with this project is that they issued a phone to the patient, and when they did that, there were questions of like, well, you're issuing them a phone, that means technically you can track them. So there are those certain issues, but again, this has been kind of like an area that I think telehealth has egregiously neglected, is like the public health area. So you're right in that usually with public health there are sort of extra protections that you guys have that really have not been kind of like main topics for telehealth, because the telehealth has focused more on that kind of provider to patient direct health services type of area. But yeah, there are issues that you probably face in that, such as when you're using it and how you're using that technology, that you're going to have to put extra precautions on.
And this is Connie from Kentucky. I would like to have some more information later when we do one of our calls about local health departments not being sites. What we're doing in Kentucky is we've written into the MCO contracts that they have to at least pay us a facility fee for putting the patient in front of a specialist. So in our rural areas, we're trying to let our health departments be the telehealth hub for the community. So we are doing that. Are we breaking any federal laws?
No. So the earlier question was around CMS and their Medicare policy related to that. So Medicare is actually pretty, CMS is actually pretty loose with like what Medicaid does and what states can do with their Medicaid program in relation to telehealth. Basically, they have like kind of this general, if you kind of like meet the requirements that it's like good service, that type of thing, you can go ahead and do telehealth. And they also issued a clarification because there was this whole debate of like, do you need to issue a state plan, or do we need to send in a state plan amendment if we decide to reimburse for telehealth? And CMS said, no, you don't have to do that as long as like, you know, they're the same services basically that you're covering if they were in person. So no, it's not about the sites. No. So when I said like local health departments aren't considered sites, that's just for Medicare, because that's like in federal statute for the Medicare program. If you want to do that for Medicaid, or if like your state just wants to include them in general when you're talking to like, you know, private health plans, that's perfectly fine. It was just like that whole, you know, what Medicare reimburses for telehealth, where they haven't added local health departments as an eligible site, and it's been kind of hard to get them to change any type of statutory limitations related to that.
Thank you, May, and thank you, everyone. At this time, I want to be respectful of time, so we will end Q&A. So we really thank you for your participation. Please use the contact information on the screen and follow-up questions, and please don't forget to respond to the survey with your evaluation. It just takes a few minutes, and it would be very useful for our future projects. Thank you very much to May for your presentation, and to each of the state leads for helping to coordinate this call. Enjoy the rest of your day.
Thank you.
Bye.
Thank you. Please stand by.